Tina Drago with Healthy Las Vegas, coming to you from KDON 720, Studio A at the Beasley Broadcast. Today I have back by popular demand Matt Engstrom with CareMore. He is going to discuss with us now the Medicare Prescription Part D program.
I will be happy to do that. Good morning.
Good morning. There's a lot to know about this, right? It gets its own segment.
So let me get this out there first.
Okay.
Do I get my picture on the wall soon? This is my third time on the show.
You know,
do I get a tattoo? What's the process?
I don't have a picture of you, but I think you're picture worthy now. I do.
Okay.
I think we can get out there and promote.
I want to make sure that I'm on the right path with you before we get into the drug coverage. So
yes, you are on the right path.
Excellent.
And no funny mustaches or anything on your picture. I promise.
Okay.
So we've talked about, let me just catch everybody up. We've talked about the difference between straight Medicare, Advantage Plan, and Supplement.
Yep.
And we have talked about what people should look for in Advantage Plan versus Supplement and what programs and services are available to them. So that was show 1 and show 2.
Yep.
By the way, I've named these shows the 1, 2, 3s of Medicare.
Perfect.
So today is show 3, and we're going to talk about drug prescription. And people, listen, you must have it. If you don't, you're going to get hit in the butt later on with it.
Yes.
So, Matt, fill us in. Why is it important for people right out of the gate when they turn 65 to make sure that they have a Part D program in their Medicare?
So let's start off with what you alluded to, the penalty. Let's talk about that first.
Okay.
'Cause I think this is one of the things that, as time has gone on since 2006 when this was first implemented, people were not necessarily aware of the whole program, but now people are starting to learn. Having said that, though, I think we want to start with the penalty. So if you are eligible for Medicare Part D, as in dog, or also known as a prescription drug plan, if you are eligible and you don't pick a plan, and you don't have a valid reason for not doing that, like you're still working, which a lot of our listeners may still be working right now.
Right.
If you're still working, this doesn't apply to you. But if you are eligible for a Part D plan, you don't have some other coverage in place, if you decide not to get a prescription drug plan, you're going to receive a penalty.
So let's break this down.
Yep.
Eligibility means if you are paying for Medicare, Advantage, or Supplement, you are automatically eligible.
Actually, it's even more simple than that.
Okay.
Because we're talking about drug coverage. So the previous 2 shows were a little bit more in depth about how to qualify and what those plans offer. But with prescription drug coverage, you can have Medicare A or Medicare B. You only have to have one in order to pick up a drug plan.
Got it.
And that's important for folks to know. It's like the Medicare Advantage plans, like the Medicare Supplement plans, you're going to have A and B. It's going to be a bundled package. But with Part D, it's A and or B. So let's say that you'll be my test subject today.
Sure. I'm 65.
Look good for 65, by the way.
you.
So let's say that you are not working, okay? You're 65, you've officially retired.
Am I on Maui? Can I be on Maui playing golf?
I feel like we're in Maui right now.
Okay,
Yeah,
good. I
it's
like
got
that.
The
Okay, so
the vibe.
we're there.
Yeah, we're here.
Okay.
All right, so everybody find your space. So let's say you're eligible for Medicare, you're not working, and you look at you see a news article about Part D. You look into it, and you say, you know what? I'm healthy right now. Things are good for me.
I juice
don't
every
take any
day.
drugs.
I exercise. I take no prescription medicine.
Right.
Why am I paying for this?
You're the vision of good health, right? So you don't need anything.
I love it.
So let's play through this scenario, and let's say that 5 years goes by. For that 5 years, you maintained your Greek statue status, right?
Woohoo!
But something changes. Now something is different in your health. Now you need prescriptions.
Okay.
So now you say, I got to go find some prescription drug plan, some coverage.
Mm-hmm.
What will happen to you, and this happens to a lot of people who don't know, Medicare will assess a penalty of 1% for every month you could have had drug coverage but did not, off the national average premium for all prescription drug plans.
So if we take 5 years,
Yes.
60 months,
Mm-hmm.
what percentage penalty is that?
Well, here's the issue. We don't know for sure. People like myself who are in the business, we can't say for sure, but what I can give you is a very concrete example.
Okay.
So the reason we can't tell you for sure what the number is it's based on the national average premium across all 50 states, all companies, all drug plans.
Oh, so it's government math.
Yes, it is.
Okay, that helps us right there.
Yeah, so let's keep it simple then, having
Right.
said that. So let's just say that $30 is the average premium. So you're going to pay 1% of $30 times 60.
So that would be $18.
Right.
Quick math, huh? Mental
Yes.
math.
She's good, folks. So let's just go with that number, say it's $18. You're going to pay that $18 every month for the rest of your life once you start that drug plan.
Okay, so has anybody done a break-even analysis on what I would have paid for the drug plan for the first 5 years versus the penalty?
I've done them with folks. A lot of people I've met have done them on themselves. The issue here isn't so much that you're penalized. It's that people aren't aware of the possibility of getting penalized.
Okay.
Now, there are exceptions to this rule. If you're still working, for example, if you've qualified for assistance from the state or from the federal government, there's a handful of situations where you'd be exempt or this penalty would be waived. But I feel like it's important to talk about this first, because while I agree with a lot of people who say, I'm healthy, I don't take drugs, therefore why should I get a drug plan? I get that, and I'm with you 100%.
Right.
But those aren't the rules we operate under right now. So the first thing you want to do is take a look at what do you have? Am I working? Am I not? Do I need medication? Do I not? If you don't need medication, if you're not taking medication, one of the things that we've advised folks to do is either to go to a Medicare Advantage plan that has a drug plan with it, or if you don't want to go that route and you want to get just drug coverage and nothing else, get the plan that has the lowest premium possible.
Okay, but is there a catch to the Advantage plan?
No.
No?
No.
So could I go from one Advantage plan to the other with no penalty?
Yes.
Okay.
Now, once you're assessed the penalty, though, it's going to follow you forever.
Right.
But to avoid the penalty, if you have a Medicare Advantage plan with drug coverage, or you have a standalone drug coverage plan, or maybe you have a plan through work that's considered to be creditable, those three scenarios would allow you to avoid the penalty issue.
Got it.
So there's more to it than this, but just for the listeners, I think it's important to start off with that.
Okay, so the bad news first. Where's
Yes.
the good news?
The good news. The good news is that the way that our drug plans have worked, so this started back in 2003 with the Medicare Modernization Act. I think it was called MIPA. That was the legislation that put this into effect. It went into effect January 1 of 2006. So that was when we first had the idea or the introduction of what's called this thing, the donut hole. We've heard about this thing called the donut hole.
Yes, for very sick patients, this is significant.
It's significant anyway because things change, our health changes, therefore we need new prescriptions, or the prescriptions that we take all of a sudden are more expensive, or So the way the drug plans work is Medicare defines what the template looks like. I'll call it the sandbox. So Medicare creates a sandbox in which any company that's going to offer drug coverage must operate in. So here's the rules. You got your box to work in. As long as you're staying in this box, as long as you're following these rules or these numbers, Medicare will grant that company approval to provide prescription drug coverage to its customers.
Okay.
So the way this template or the way this sandbox works is there are 4 phases to your drug plan. Phase 1 is called your deductible phase. Now, it's important for the listeners to make a note that what I'm about to talk about is the standard benefit. What you may have right now could be better, could be worse. Well, actually, no, I'm sorry. It could not be worse. It will be at least as good as what I described, if not better.
Okay, so this is one layer.
Right.
So let's say this is for Medicare, straight Medicare people?
Not even that. Not even that. So Medicare, the numbers I'm going to go over here in a second, Medicare lays these out to every company, every consumer. And for the companies that want to offer drug coverage, they have to be at minimum as good as the numbers Medicare puts out.
Okay.
Now, if they want to make it better, which most companies do, those numbers may change.
Okay.
So your first phase is called your deductible phase. Now, for 2015, that's $320. So if your plan mirrors this first phase, when you first go to that pharmacy, you would be responsible for $320 out of your pocket.
So if you're a diabetic, the month of January every year is on you.
Little expensive, yes.
Yes. Okay.
Now, I will say from experience that the majority of plans these days don't have a deductible, but they are out there.
Okay.
So you want to take a look at what you have and compare. So that's stage 1 or phase 1, your deductible phase. Stage 2 is what we call your initial coverage limit. And this is where people get confused. So you're starting off the year, think of it like this. You have a bank account. In that bank account, there's $2,960 that you and your company will use to pay for medications.
Okay.
So I call this your copay phase. And what I mean by this is, let's say for simple math that I have a prescription for a $100 drug. And the plan that I'm on says that they'll cover that medication for me at say, $30 copay. So keep in mind the cost of my drug is $100. So I'm paying $30, which means my company is going to pay the remaining $70.
Okay.
When you take the amount of money that the company spends plus the member spends, you call that your total cost.
Okay.
So I go to the pharmacy, I pay my $30, the company pays $70. That total of $100 is now deducted from that bank account of that $29.60.
Wait, but they're double dipping on my 30.
They are, sort of, not really.
Well, the 30 came out of my pocket and came out of my benefits.
I know. Call your legislators if you don't like it.
That's a double dip.
I've heard that sentiment before, but
Okay.
that is the plan that we operate under, and it's the same rule for all plans across.
Okay, so let's hear the next
So
scenario. I'm not liking this.
call it a double dip, call it what you like, but here's how this works, and this is the most crucial part to this. So that $100 that we have spent together is taken away from $29.60. So now I have what, $28.60?
$28.60, yeah.
So every time I go to the pharmacy, whether I'm going in person or it's mailed to me, the total that is combined is deducted from whatever that balance is.
Okay.
Now, it's not literally a bank account. This is just a great example for people to
Right.
visualize. So this is the reason I call it your copay phase, because if you have a plan that has enhanced coverage beyond the Medicare standard, you're probably going to have copays. You'll see tier 1 might be $0 for generics. Tier 2 might be $5, $7. Your name brands would fall under tiers 3 and 4. There's a tier 5 for specialty medications.
We all see those on our insurance cards, and nobody knows what they mean.
Yes, and that's exactly what we're getting at.
Okay.
Right? So just to clarify, the Medicare standard for this $29.60 is that the member pays 25% and the company pays 75%. Most companies don't follow that logic or that math. They'll have a copay written down for the patient, and then they'll pay whatever the balance is.
Okay.
So I'm starting off every year with this mythical, magical bank account, and this year it's $29.60. So every time I get a medication, that total cost is deducted from that $29.60.
So the $29.60 is an arbitrary number that the government has deemed every person should be allowed in prescription costs?
Yes.
And it changes annually?
Yes. And it's actually getting better, and if you remind me, we'll get to that towards the end of our time. So I start off January with $29.60. Let's say I use that up. And frankly, there are people that use that $29.60 up in the first 3 months.
Yep.
Some in the first month. And then you also see those that maybe towards the end of the year, October, November, they'll have exhausted that money. But let's say that you do that in March, in April. So now there's going to be a change. You've used up your $29.60. You're out of that initial coverage limit phase. Now you're entering what's called the donut hole.
Dun, 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 dun.
I don't like the name because I think it's misleading. What do donuts have to do with drugs? You know, that's how I look at it.
It sounds sweet and nice, but the truth of the matter is you're going into the black hole.
Technically, officially, it's called the coverage gap.
Okay.
Now, here's where this is important, and here's why this changes. So, in the example I just explained, I called that your copay phase. Meaning, you could look at your book, or you look at the back of your card, and you'll say, okay, I got a tier 1, I got a tier 2. I know my copay because my book tells me what my copay is.
Right.
That's not the case anymore. Instead of having these preset copays, you're going into what I call the discount phase. And the reason is when you go into this coverage gap or donut hole phase, the amount of money you pay for your medications is going to become a percentage. It's also called coinsurance. So remember in the example, I had a $100 medication, so that would imply it's probably name brand, right? I'm paying a $30 copay for that first $29.60. Now that I've used up that $29.60, now that I'm in the donut hole, I'm going to pay a percentage of 65% for that generic Medicare, or I'm sorry, 45% for name brands, 65% for generics. So instead of me paying $30, I'm now going to pay $45 because I'm paying 45%.
Okay. Now I'm gonna take you back 1 second. You said that the government on the $29.60 ideally wants the insurance companies to pay 75% and the individual to pay 25%. But when I do my mental math, $30 as a copay is more than the 25%. So people should be aware of that, right? Look at those copays and make sure they're not front loading.
Right. And a lot of companies, so keep in mind that 25% is the baseline. It's the minimum.
Okay.
Once
it's the minimum.
Yeah, once the company is approved, they can make it better, which is where you get these copays.
Okay.
Because the copays are nice because you can predict, you can know ahead of time, what your costs are going to be.
You got to shop for insurance like you shop for a car. You got to really put your time and effort into looking at all the bells and whistles and the safety features and all that stuff, and make sure you're getting good gas mileage. And you really should look at your insurance company the exact same way.
And I would also advocate you do your research in the context of finding somebody who can explain this in a way that makes sense to you.
Yes. If you glaze over, get another person.
Exactly. And the truth of this is I've been doing this for 11 years. And the bottom line is if you do a good job of educating people and you answer their questions and you can return a phone call, most people are going to do business with you.
Return a phone call?
It's crazy. I know.
An insurance company that does that?
I know, right? We're so revolutionary at CareMore. We actually call you back. No,
I have to tell you, folks, that doesn't happen. I mean, we run a medical clinic, and it doesn't happen. Yeah. So that would be phenomenal. That actually is something you really should raise your bar to and expect.
Right.
You are the client.
If you do a good job of educating people and you tell them what the real deal is,
you've mitigated their expectations.
Most people are going to do business with you.
Yes.
So find somebody that does that for you, that you feel comfortable with, that when they explain things that it's done in a way that makes sense and you're cool with it or you're comfortable with it.
If they hand you a large book with small print and say everything's in there, no. Yeah. Tell them to go through it with you.
So what we're going over here, this is the condensed version of how the drug plans work.
Right.
I have to imagine that somebody who hasn't really had to deal with this before, that goes into the journey of educating themselves, it's going to be pretty daunting. I'm
telling you, this is how it all started. My husband turned 65. He's a healthy person. Mm-hmm. He takes no drugs. He has no prescriptions.
Yep.
And I'm sitting here going, oh my gosh,
yeah.
This is, and I'm in the business, and this is crazy.
Yep.
And it seems like just in the last couple of years, more programs have come out that are obscure that I haven't heard of.
Mm-hmm.
Symphonix and SilverScript and all these things that I'm like, who are these people and why are people buying these? Because they're not paying the provider. I hope they're paying the insurance. No, they're not paying the provider. They're mostly HMOs. They have maybe 3 or 4 providers they work with.
Yep.
And because I get it from the other end.
Yep.
We provide the services, and the last thing we want to do is go back to the patient and say your insurance company didn't pay us.
Yeah. Yeah.
So
find somebody that you feel good with, that is going to give you the real education. And those are generally the people that you're most comfortable with, especially in this field when you're talking about not only health insurance, but I would say the insurance industry in general, especially financial planning. You want to find somebody that you can work with, that you're comfortable with. But for this stuff that we're talking about now, I'd really think that you got to find somebody that you can talk to, that calls you back. Now, when I say call you back, I don't mean 10 minutes later, but I mean within 24 hours, 48 hours.
A week would be nice.
My goal is always 24 hours.
I like that.
Doesn't always happen, but that's the goal.
Okay.
So let's get back into the coverage gap, because this is a crucial piece for the listeners. Yes,
coverage gap's a big deal.
So remember, you're going from a copay to a percentage. So in this example, I've paid $30 for my name brand medication. Now I've got this it's called a discount. It's a co-insurance. Let's say I'm paying the 45%. So now I'm paying $45.
Right.
As opposed to the $30.
And how long do you pay $45?
Until you have used up $4,700.
Is that $47 on top of the $2,960?
It's
or is it $2,960 to $4,700?
The cumulative.
Okay, so between you're in the black hole. I'm not going to call it the donut hole because that's lying. Between $2,961 and $4,700.
Mm-hmm. Right.
You're in the black hole.
You're in this, yeah.
It's okay. So
pretty severe example, but yes, because you can get out of it unlike a black hole.
Okay, so some people feel like they're vulnerable and they're sucked into it and they don't know. And it's coming at them. And these are the most sick people. I mean, I deal with people that are, hypertensive, diabetic. They have autoimmune issues, and they use up their $2,960 very quickly.
Quite often, yes.
And now they're looking at dealing with money that they don't have because it's not in their budget.
Well, yeah, I've always said that you should never have to make a decision between food and drugs. And that's a decision that, to your point, a lot of people have to make. And so not only do we want to provide education on how this works, but if we have time, I'll kind of go into some of the options in terms of assistance. So follow me here. You're paying your discount. You're paying your discounted rate. Right. In this example, it's 45%. One thing that's really important that's newer last couple of years is even though you're paying this percentage or this discount, the way that the numbers are going to track in the system, it's going to show as if you spend 100%. That's important because that amount of money between $2,961 and $4,700, you'll go through that faster when you're getting 100% credit as opposed to getting 45% credit.
That's true.
Right?
Okay, so there's a plus.
So, if you've gotten to the point where you've exhausted that $4,700, so you go through your copay phase, you go through your discount phase, now you've used up $4,700, you enter the appropriately titled catastrophic coverage phase.
Yes.
So they got one name wrong with the donut hole, they got one thing right with the catastrophic coverage. The reason this is called catastrophic coverage is that 95% of the cost of your drugs after $4,700 are going to be paid for.
So now we're back down to 5% is our cost.
You're going to pay 5% or a small copay.
Okay.
And that small copay is not going to be bigger than $6.60.
Oh.
So it's actually whichever is greater. It's 5% or $6.60. And you'll pay that 5% or small copay for the rest of that year.
Okay.
So there's a couple things we want to bring out here for the listeners. Number one, if you're concerned about these costs, don't worry. You're not the only one. This is the same model, same logic that all companies follow. Now, the numbers that I've gone over could vary from company to company, from state to state.
And will vary year to year.
Yes, they do vary year to year. So I say that, though, if you're listening to this and you're in, say, Canada, it doesn't apply to you. But if you're in Minnesota or Oregon, it would apply to you. But check the company that you have, because the numbers may be different.
Okay.
The logic and the sequence I went over is the same. It's the same everywhere.
Okay.
So a couple things. Number one, you might want to have a conversation. You should have a conversation with your physician or physicians about the types of medications you're taking, meaning name brand versus generic.
Right.
Now, you and I know that there are some medications that have a patent. They're not going to be going generic for quite some time.
Yes.
That's probably a separate show, but...
Matt, can we have you back again?
I would love to. Anyway, yes, that'd be great. Talk with the doctor about your medications and what alternatives there are. Now, I know and you know there are some people that can't take generics for whatever reason. We get that.
Right.
Point is, have the conversation. Make a point to have that conversation. Even if you got to pull your doctor by the hand and say, no, I need to talk to you. Make that happen.
Don't be afraid. Please, 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 please do not be afraid to explain to your doctor that you're on a budget, that you have financial restraints, because what they're doing is they're prescribing usually the latest, greatest, whatever farm rep came in, whatever's out there. They're prescribing that to you, thinking that they're giving you the latest technology that's available to you. And don't be afraid to say to them, hey, doc, I'm not going to be able to fill this prescription because it's way over my budget, or I can't afford the copay on this. They will very quickly turn it around because they're not in the business to write scripts that you're not going to be able to fill.
It only comes back negatively on them.
Completely negative. And so please have those conversations. The doctor will appreciate it. You'll appreciate it. Everybody will win in this, and never feel like you can't, because some of these pharmaceutical drugs, the doctors are oblivious to the costs of.
And some willfully, I have to say. So you bring up a good point, though, because what I remember recently we had a member who was concerned about the cost of her medications. And I had been telling her, you need to speak with your doctor. And she was not comfortable doing that. And so I put it in perspective for her. I said, would you rather have maybe 3 minutes of anxiety, of discomfort having this discussion, or would you rather pay thousands of dollars unnecessarily? I know we're short on time, but this is a kind of a basic rundown of how Part D works. The best thing that you can do, frankly, is to come to an appointment, I wouldn't say come to an appointment, make an appointment with somebody so that we can take a specific look at the medications you're taking and compare those costs to what they would be on the plan that you're considering.
Everybody's unique. Everybody has
Exactly.
different circumstances, and that's one of the things you should really look at is you shouldn't be in a blanket program. You should be speaking specifically about your situation.
Now, we as Medicare agents, I guess, in the industry, we don't ask people for their medication lists, but a lot of them will give it to us. Because if you were a prospect or somebody I was working with, a client, if you gave me your medications and I was, say a broker, I could go through each company and run a scenario on each company's plan. I could tell you, Tina, this is the one I recommend for these reasons.
Right.
So we don't actually actively ask people for their medication lists.
Everybody should bring that, though.
Right.
Everybody should bring it, and you can get it from your doctor. Your doctor has a running list of your current medications.
And don't take everything that we've talked about to be 100% true, because like I mentioned, some parts of the country, some plans, these numbers I went over are going to be different. So if you're going to do the research, make sure it's localized to your area and also to your specific situation.
Excellent. I really appreciate you. I hope everybody learned something today. I sure did. Thank you,
Thank
Matt
you.
Engstrom with CareMore, telling us the ins and outs of Part D Medicare. This is Tina Drago with Healthy Las Vegas, coming to you from the Beasley Broadcast Studio A. I hope everybody's having a wonderful day, and don't forget, call your doctor, and if you don't have one, First Person Complete Care is there for you, 702-380-8118.